Sometimes patients just have such a large disc herniation or they have such severe stenosis or narrowing of the spinal column that it puts a lot of pressure on the nerve, which can cause different varying degrees of numbness, weakness, or even pain that shoots down the leg. And in those instances, it may be appropriate to proceed with looking into surgical intervention. The goal of the operation has not changed. That is to remove whatever is putting pressure on the nerves, whether it's a disc herniation, bone spur, or arthritic overgrowth. That goal has not changed, but our ability to get down to the spinal column with a much smaller incision, which allows a lot more of a rapid recovery, has greatly improved. Say, for example, a patient has a disc herniation or a bone spur, we can make a tiny incision right over that site. The best approach is from the posterior approach or from behind, and we make a small incision. We place a tube down to the spinal column. It's a little tiny tube, and then under a microscope, we're able to make a little window into the spinal canal, find the problem, usually the disc herniation or the osteophyte. You identify the nerve that it's putting pressure upon, and then you want to remove that fragment or whatever it may be that's putting pressure on the nerve out of the channel where the nerves travel. Nowadays, these procedures are done outpatient. Patients go home that same day. I usually advise patients to wait a week or two before they go back to work, but my restrictions are mostly physical restrictions, and I even had one attorney not too long ago go back to work, the next day. If it's a patient that's had a large disc herniation, they got to our office, to our practice relatively quickly, within a month. Sometimes in the recovery room, they can immediately tell that the pain's gone, the foot's working better again, or the numbness is better.